Hello everyone. Today in this presentation, I'm going to talk to you about one of the most important topics that would help standardize or increase the acceptance of the gold standard therapy, which is continuous positive airway pressure or any kind of PAP therapy. So the title of the discussion that we're going to have in the next 15 minutes is the impact of sleep surgery on CPAP non-adherence. Now, CPAP non-adherence, as you will see in the slides to come, is one of the biggest problem, so to say, the elephant in the room when it comes to CPAP treatment. And it is more important because it is considered the gold standard therapy. So we're going to investigate strategies to enhance compliance with sleep therapy with CPAP. Right? So let's go. Now, adherence and compliance. These are two sort of words that are used very synonymously, but they both basically mean the same thing. How effective is the treatment that is given to the patient with sleep apnea, gold standard therapy? So, as you all know, the most effective treatment, where appropriate, is PAP therapy. However, many patients do not use CPAP enough to benefit them, and the adherence rates have remained unchanged in the last 30 years. There are lots of papers that have basically talked about the flattening curve of CPAP adherence over the last many years. Wonderful paper that got published in 2015 from Brian Rottenberg and Kenny Pang. And in trials, it has been shown that 17 to 70% of patients are non-adherent to CPAP using the widely accepted criteria, which is the 4 hours nightly use for at least 70% of the night. Now, this number itself is plagued with controversy because it has been shown that um, when you use it only for 4 hours, there is no benefit in terms of cardiovascular morbidity or uh, efficacy in terms of diabetes treatment. And somehow this number has basically come or has come to be because of various studies that have been done to sort of help execute the insurance, especially in the West and also in the developed countries. Even once on treatment, once you've given the CPAP, an obstacle to good clinical outcomes can result in deleterious consequences for our patients. Imagine uh, there are arrhythmias or there is uncontrolled hypertension, and a person has been prescribed CPAP and he doesn't use it. So the clinician who's advised it is oblivious to the fact that the person is not using it. Of course, with the new cloud-based technology, we are able to trace and track how well our patients are. That doesn't seem to be the case in many situations. So once on treatment, if the gold standard therapy is not adhered, there will be deleterious consequences. So if you look at compliance of CPAP in patients with obstructive sleep apnea, there are certain observations that have been highlighted in this very nice paper that got published. So here they sort of highlight the fact that socioeconomic status and the Caucasians have shown better compliance when as opposed to other races. There may be many reasons for that, but this is not the platform to discuss that. The second very important factor that has been highlighted is nasal disease significantly impacts PAP therapy compliance, right? That means acceptance to PAP therapy. However, using just intranasal topical steroids did not improve CPAP therapy compliance. Using an intranasal, an INCS, an intranasal corticosteroid is a low-lying fruit. You would definitely like to use it. But if you just use a topical INCS, it has been found that there is no improvement in CPAP compliance. So, what are the best predictors based on evidence for continuous positive airway pressure adherence? Now, this is a very nice table and chart. So, if you look at best predictors, the best predictors are residual apneic and hypopneic events in spite of using CPAP. So, if you have used the CPAP and there are still residual events, that means the person is probably not going to adhere to this type of therapy for a long time. The second best predictor is nasal volume. Please remember, nasal volume. That means the volume of air that the nose is carrying. The third predictor is black race. The fourth predictor and the golden time of use when it comes to CPAP is the first 2 weeks of treatment. The next factor is active and planful problem solving is another very predictor for acceptance of CPAP. So if you the clinician is very active and they come out with a planful problem solving uh, technique, like you sit with the patient and then you actually try to sort it out for the patient, it is a good predictor. So you need to invest the time with the patient. The last but not the least is if somebody has claustrophobia, then it becomes very challenging. Now, there are certain factors which have conflicting evidence. For example, severity of disease. That means whether severe AHI or ODI, BMI, pre-treatment, daytime sleepiness or quality of life parameters, old age, humidification, partner relationship, and self-efficacy. These are factors that are there. We have found some of them to be a significant predictor, but the evidence is very sketchy. But what are not predictive of long-term adherence to PAP therapy is mask and technological interface. The second factor is the pressure settings. That means some patients do very well with low pressures, some patients do very well with high pressures. So so just the pressure itself is not a predictive factor for CPAP compliance. So you yourself must have seen it in your practice that some patients accept very high pressures. Medical comorbidities and the side effects that CPAP have in terms of bloating and all, um, differences in sex, differences in income, sleep literacy, anxiety, so on and so forth, have not been predictive of CPAP adherence according to literature. So let's take one of the most important parameters, which is the second most important predictor for CPAP compliance, which is nasal obstruction. So we will stick to this particular entity, which is the nasal obstruction and its influence on CPAP adherence. So if you quote literature, there are lots of side effects that have been flagged for CPAP, especially when you use nasal masks. But why won't you use a nasal mask? Because it has been shown that the nasal mask is the most comfortable mask. So you would use it. Now, this is a very nice study of about 193 patients in French sleep centers. And they found out that dry nose or mouth in the morning affects 65% of the patients when you give CPAP. Sneezing and post-nasal drip were present in almost 35% of patients and nasal congestion in 25%. Now, nasal congestion is a very dubious word. I mean, when you use that word congestion, a lot of times you're not sure what the patient is really sort of expecting for us to understand. Is it secretions in the nose, or is it a blockage? So it's very important that we find out. And amongst all the factors, when you actually measure it in a very objective way through rhinomanometry, it has been found that nasal resistance is one of the most important factors that influence the decision making whether the patient is going to accept CPAP or not accept CPAP. As you can see, nasal resistance measured by rhinomanometry in patients who have acceptance, it's 0.36, whereas in non-acceptance, it's about 0.66. That means the lower the nasal resistance, the better the acceptance. Also, it has been found that for long-term CPAP adherence, we're not talking about short-term, long-term CPAP adherence in patients with OSA can be predicted from the initial CPAP adherence. Remember that I was highlighting the fact that the golden period, that is the first 1 month, how much the patient uses it or adheres to the treatment, that determines whether the patient is going to accept the CPAP therapy in the long run. Treatment adherence gradually decreases in patients with nasal complaints, and hence asking the history and evaluating for nasal complaints is very, very important if you want to achieve long-term adherence with CPAP. Nasal disease and nasal parameters were important factors in influencing that early discontinuation of PAP therapy. So it would be our failure to sort of not pick up that particular aspect of nasal complaints, and that would be the stepping stones for disastrous results when you give the CPAP therapy. Now, in these patients who have been flagged with nasal complaints and who we think will not be adherent to CPAP therapy, if you were to do a nasal surgery in them, so who are these patients who will do well? So these are the patients who have severe nasal congestion at bedtime. And severe nasal congestion is one of the commonest factors for sleep initiation insomnia, which is one of the commonest sleep disorders. History of sinusitis, and slight or extensive CT sinus shadows on CT. So the higher the Lund-Mackey score, the higher the chance of non-acceptance. And again, nasal resistance measured by by rhinomanometry has been found that when you measure nasal resistance with a rhinomanometry in supine position, if you find that to be more than 0.3 pascals per centimeter per second, it has been found to be a predictive value for a nasal surgery. Here is another paper again saying the same thing, but this is talking more in terms of just not septal deviations, but inferior turbinate hypertrophy and tonsil hypertrophy and palatal grade. But let's stick to the first two. And they have basically found and divided these septal deviations based on the severity that the septum has sort of deviated from the crista galli. If you draw a line on the CT from the crista galli to the maxillary crest, the degree of variation from that line has been graded. So it has been found that patients who are adherent to CPAP have hardly any deviations from the center line, whereas non-adherent patients obviously are at a higher score. And the same thing is true for inferior turbinate hypertrophy. The higher the turbinate hypertrophy, the poorer is the acceptance of CPAP. So how do you sort of assess and manage this? Well, when it comes to the nose and nasal obstruction, there are always medical conservative methodologies and there are surgical methods. So I would like to bring to your attention some very common myths or misconceptions. This is a paper that got published way back in 2009. which has highlighted the importance whether whether it's heated humidification or intranasal corticosteroids that matter when it comes to CPAP compliance. And they found out that the addition of heated humidification and not INCS decreased the incidence of nasal side effects in OSAs. That is very shocking when I've actually read this article. The compliance rates and quality of life remains unaltered by these interventions. So it has been found that it's the CPAP itself, compliance rates on quality of life, that is patient-related outcome measures, they are unaltered. But these side effects, if you add humidification and not intranasal corticosteroids, the incidence of nasal side effects has reduced, right? So that is why giving INCNs is not an option. Why so? Have you wondered? Because most of these patients, when we give intranasal corticosteroids, one of the most commonest side effects what is nasal epistaxis? Why does that happen? That happens because of dryness. And once there is dryness, there is increased blockage, increased congestion that the patient reports. Why? Because the nose does not have touch receptors. It only has thermal receptors. The receptors of the trigeminal nerve that are these are the trigeminal receptors. These are, I think, TRMR receptors. No, not TRMR. These are the, mm, I think, uh, TRM8 receptors, if I'm not mistaken. Anyway, so these sense the air entry, and once the air enters into the nose, there is a cooling phenomena that these trigeminal nerve receptors pick up, and this is relayed to the brain as air getting inside. Um, TRM8, I think this is the name of the receptor. TRMR is the ankle glacier grading. Sorry. So when it comes to nasal side effects, humidification helps, intranasal corticosteroids do not help. Again, this is another paper that got published a little after that in 2011, titled Topical Nasal Steroid Treatment Does Not Improve CPAP Compliance in Unselected Patients with OSAs. This is a randomized, double-blind, placebo study with fluticasone propionate, about 100 micrograms into the nasal cavity twice daily, and that's a pretty high dose. When we give 26 or 27 micrograms. And again, the inference, fluticasone propionate as a topical nasal steroid does not reduce CPAP-induced side effects, that is nasal side effects, and has no beneficial effects on CPAP compliance during the first 4 weeks of treatment. Why is that first 4 weeks of treatment very important? Because we know now that the first 1 month determines whether the patient is going to accept this therapy for in the long run or no. So when you look at paper after paper, this is another very nice publication from 2020, again saying the same thing, that fluticasone propionate as a nasal topical steroid did not reduce CPAP-induced nasal side effects. Um, so paper after paper sort of talking about the same thing. So giving an intranasal corticosteroid, especially the non-aqueous form, does not improve compliance. So once you've decided or thought about medical management, it is very important that we talk about the nasomaxillary complex. Now, this is very important, right? Now, this is very important because you shouldn't be just looking at the nose. You need to take care of or talk about the nasomaxillary complex. Now, because the roof of the mouth is the floor of the nose, we are not talking about two independent what should I say, the factors, they are both same. Now, let's talk about the roof of the mouth. As you can see in these patients, the first thing that is seen is the facial profile, and the moment they open the mouth, you can see that all of them have a very narrow, high arched palate. That means the intermaxillary, premolar and molar distance is very small. So what happens? What if it's small? So what is happening is something called as loss of coupling, wherein the tongue is falling backwards and falling into the airway. In fact, in these patients, if you do a nasal dive and you see an AP collapse, and if this patient turns out to be a mouth breather, always do an intraoral dive to see if there is loss of coupling. Why? Because if the tongue is falling backwards and crushing the soft palate, giving an appearance of an AP collapse on nasal dice, we would be in trouble. Because thinking that it's an AP collapse, we might do some kind of a procedure to the palate where it would be disastrous, because we would just do a palatal surgery and get away. Whereas the problem here seems to be loss of coupling and the tongue is falling back into the airway. So how do you take care of this situation? So I would like to highlight the fact that always think of the container and the contents kind of a scenario. So here you can see wherein there's a clear cut and very narrow piriform aperture. You can definitely see how narrow the base is. And based on whether it is narrow here or here, you can actually do either a transoral piriform plasty or a transoral approach, that is translabial approach. Or if the narrowing is higher up, you can actually do a transnasal approach, use a burr, use a piezo, whatever it is, you can address this part. Whereas if it is the lower part, that is narrowing at the internal nasal valve area caused by the narrowing of the at the level of the floor, then it's probably a good idea to do a Lefort 1 osteotomy and then put a MSC or a MSC expander and then expand. Here you're seeing two different approaches, a transnasal approach to the piriform plasty and a transoral, a translabial approach. So there are many ways that you can attack this basic problem. In the future, I would definitely take a separate talk on this specifically, because this is something that is very dear, and it's of course very important that we identify this. Now, all of us as ENT surgeons do address the contents issue. Here, I'm highlighting the fact that there is something called as a septal tubercle, or you can also known as septal swell body, wherein this would prevent the air from entering into the middle meatus. So here we are using a coblation device, wherein this is a regular turbinate wand. This can be done under local anesthesia as well, and the results are very obvious immediately. You can, when it comes to turbinates, you can either use radio frequency or you can use coblation, whatever may be the fact, a technique. It's all about how you achieve it. But it has been shown that when it comes to turbinates, when you do any kind of procedure involving the microdebrider or using partial turbinoplasty techniques with cold steel, the results are more sustained and long term. So there is, I cannot emphasize enough the role of objective measurements, because there are very good results that have been shown. Um, when we do objective assessments, because a lot of times patients themselves cannot tell the difference. And that is why it has rhinomanometry has helped me a lot pre-op and post-op. So it's very important that we actually follow an algorithm when it comes to sleep surgery, and this is something that I found to be extremely important when it comes to sleep surgery. And this is something that I follow to the Z. Um, so if the problem is BMI, just go ahead and do weight loss issues. But if the problem is a nasal obstruction, if it involves the internal nasal valve, you need to do some kind of a stabilization procedure. You can do a septorhinoplasty with spreader grafts. If the problem is deviated septum, do a septoplasty. If the turbinate hypertrophy is the issue, do a submucosal resection or RF. But the problem is a nasal floor. You'll need to do some kind of a medically assisted rapid palatal expansion or a distraction osteogenesis maxillary expansion. But if the problem seems to be skeletal purely, and based on if it's an AP deficiency, you need to do an MMA. If it's a narrow maxilla, you need to do like things like dome. And if it's a deficient chin, so you need to really differentiate whether if it is retrognathia or retrogenia. If it's retrognathia, you need to do some kind of a bilateral sagittal split osteotomy and bring it forward. Always do it in combination with the maxilla as well. But if it's retrogenia, you can get away with a mortised genioplasty. If you think that the problem seems to be a soft tissue, always do a DICE uh, and accordingly do whether whatever modified UPPP or tonsillectomy. If it's a lingual tonsil hypertrophy, you can use TORS or coblation. If it's a large tongue, a lot of times nowadays we are reducing doing midline glossectomy. If there is a tongue-based collapse and if you think tone is the issue, make sure that it is not just because of the narrow upper jaw, the loss of coupling. Now, here is the, let me just, saying poop. Oi. Yeah, this is too less. Amma, stop please.
Stop.
His airway is open here. What else you want? Or guys, they will just, by now they will desaturate.
Good
and they'll be like,
response, right?
yes.
Muzzle that is the best course.
See, కొంచెం పెట్టంగానే open. Epiglottis. Must stop, stop. ఇక్కడ లేవట్లేదు. Epiglottis is a bit. కానీ అది 44 rupees. ఓకే లేపుదాంలే లేపు. కమా లెట్స్ డూ ఇట్. నేను పట్టుకోవాలా? జస్ట్ నేను పట్టుకుంటా. Yeah, this one's better. పెరుగుతుంది. కనిపించట్లేదా? లైట్ వేసి ఇంక్రీజ్ కొంచెం. This is perfect.
Yes.
We need more. We need more.
More?
We need more seats.
Yeah, this is not an advancement.
అదే అంటున్నా.
25% of advancement.
Must do it more.
This?
Yeah.
50% this is.
అంటే ఎంత?
Out of total 14, this is 7.
7.
7 millimeter.
7 is good.
7
See, at 51, it's good.
But saturation is not improving.
Wait, చేద్దాం.
Actually, 90 per hit. There is saturation. Like
L set.
L set is 90.
90. He didn't have nothing.
Not even
below 80.
single desaturation less than 90.
In first one, he
Open
had.
airways.
Pretty open airway.
Yeah. ఇంకొంచెం చూద్దామా సార్?
అవునన్నా సరిపోతుంది. సాట్స్ పికప్ కావట్లేదు ఏంటా అని చూస్తున్నాను. Hey, put some nose drops. Maybe the nose is not open.
Yeah.
Nose is not open.
Right turbinate.
Right turbinate is
yes.
completely blocked. See,
You can't mount the